Spin Essentials, the core topics in pediatric neuroimaging essential for daily practice, packaged as our holiday gift to you.
Welcome to Essentials in Pediatric Neuroimaging. My name is Dr. Chris Wong from Hong Kong Children's Hospital. In this talk, we are going to discuss orbital masses and lesions other than eye group lesions. Before I start, I want to tell you that orbital imaging was always difficult to me when I was a trainee because I haven't established a systematic approach in looking at images. Therefore, I'm not going to talk about fine details of each and every pathology in the orbit today. Instead, I would like to share my approach to orbital masses or mass-like lesions and illustrate some important points in orbital imaging with you. The approach is actually the same for imaging other pathologies in the rest of the body. It all starts with anatomy for localization of the abnormality. And then we think about the possible differential diagnosis for the pathologies, and then we correlate those findings with the individual pathophysiology. First of all, about the anatomy, we have to appreciate that the orbit is a complex structure that is often described as a cone-shaped structure. I group at the front and the cone-shaped structures at the retroorbital region here. The bony orbit form a cone-shaped structure, and the extraocular muscles are forming a muscular cone within. So this is the ice cream and the ice cream cone. It means that we almost always image structures in some degree of oblique planes and may not have the true short axis or long axis of all structures we imaged at the same time, and this makes image interpretation difficult. So to make things easier to understand, we have to be familiar with the orbital anatomy, and it means understand the spaces and the contents. First, it helps identifying the center of the lesion, which may give hints to differential diagnosis. Secondly, it is important to indicate extent of the lesion for management and monitoring. And usually, the orbit is divided into three spaces: the intraconal space, which is yellow here, and the muscular cone in orange here, and the green area here, which indicates the extraconal space. And we can appreciate the same structures in the coronal plane here. Because of the nearly enclosed location of intraconal space, we usually think about neurovascular or lymphatic lesions in the intraconal space first. On the other hand, the extraconal space is located at the periphery of the orbit, so we will think about the soft tissue or bone lesions that will come to mind for the first differential diagnosis. And now I would like to go through some common and important pathologies to illustrate this. So I would skip tumors of the eye group, which will be another talk by my colleague. And I will focus in intraconal masses, which include tumors of the optic nerve and other masses without optic nerve involvement. And then I will talk about the extraconal tumors. So first, optic nerve glioma. Actually, optic nerve glioma and optic pathway glioma are not histological names. Most of them are actually pilocytic astrocytoma. And it is the most common intraconal tumor in childhood. The presenting of the mean age at 4 to 5 years of age. If it is symptomatic, it may present earlier. It can be an isolated condition or associated with NF1. For the tumor behavior, it is a slow-growing tumor, so many patients are asymptomatic. Or when they presented with symptoms, they may present with decreased visual acuity or ptosis. Concerning the imaging findings, they presented with fusiform enlargement of optic nerve with tortuosity. So you can see in this case, this is the enlargement of the optic nerve, And actually, the optic nerve substance is enlarged, and there will be kinking and tortuosity of the nerve. Concerning the tissue categorization, it is T1 iso to hypointense to rest of the optic pathway, and T2 slightly hyperintense. And it shows variable enhancement pattern. Hemorrhage and calcifications are rare. Posteriorly, it may extend into the optic canal and even more posteriorly to the retrocanalicular portion of the optic nerve. And the optic pathway glioma, on the other hand, can extend into the orbit. So when we have bilateral involvement of optic nerve glioma, we have to think about the NF1. So here's a patient with optic nerve glioma. You may appreciate the fusiform enlargement of the optic nerve here on the T2 weighted sequence, and also in the post-contrast enhanced T1 weighted sequence with fat suppression. So the nerve substance in the middle of the optic nerve shift complex here is enlarged, and it is slightly T2 hyperintense and shows patchy enhancement on the post-contrast enhanced imaging. And there is a rim of T2 hyperintense signal here, which also shows some degree of enhancement, and making this region slightly heterogeneous in appearance. So this region is the perineural arynoid gliomatosis. So the hallmark of optic nerve glioma is fusiform enlargement of the optic nerve, the nerve substance itself, with tortuosity. Important differential diagnosis for optic nerve glioma is the optic nerve shift meningioma. Optic nerve shift meningioma is a homogeneously enhancing mass that surrounds the optic nerve. So this is the enhancing mass, and this is the optic nerve. It is homogeneously intermediate signal on T1 and T2 weighted sequences, and it shows calcifications occasionally. The optic nerve can be at the center of the mass or can be eccentrically located. Instead, optic glioma actually is the expansion of the optic nerve substance itself. So the difference is one surrounds the nerve, one expands the nerve. And as a tumor, it will distort the adjacent structures, as you can see the flattening of the sclera here and the displacement of the medial rectus muscle here. So hallmark of optic nerve shift meningioma is enhancing mass surrounding the optic nerve. Next, we come to intracorneal lesions other than optic nerve shift lesions. So we have two as an example. One is vascular malformation, including the lymphatic malformation and the venous malformation. And we can have capillary hemangioma in this location as well. For lymphatic malformation, it is a low-flow vascular malformation. The patient will present with acute proptosis. Interestingly, it can be related to the intralesional hemorrhage and after the upper respiratory tract infections, giving rise to enlargement of the lesions, and the patient can present with orbital swelling. Concerning the imaging findings, it can be intracorneal and extracorneal, or either one, and it sometimes involves the preceptal regions of the orbit as well. So it is called a transspatial involvement. Concerning the tissue categorization, it is T2 hyperintense with thin septa, and if there is previous hemorrhage, it may present with fluid level as well. It can be divided into microcystic, macrocystic, or mixed macrocystic lesion, and the cutoff for the cyst for macro and micro is 1 centimeter. It usually doesn't have any contrast enhancement or may have some minimal enhancement at the rim or at the septa. If this is a combined lymphatic malformation and venous malformation, the venous component can enhance this. And one important point is that there shall not be any fold signal voice within the lesion, which will suggest a high fold lesion. So in this patient, you can see the fluid levels here, And this patient also has hemorrhage in one of the cysts, showing that the T1 weighted sequence to be of a slightly hyperintense signal. So hallmark for lymphatic malformation is transspatial lesion with fluid levels, T2 hyperintense with no or minimal enhancement. Then we come to vascular tumor. Capillary hemangioma. Capillary hemangioma is the most common tumor of infancy. 60% of them occur in the head and neck region. And one very important point is about its clinical course. It is apparent within the first few weeks to months of life. And then it goes to a proliferative phase, which can last up to 10 months, and then followed by a short period of stabilization. And finally, it comes to a prolonged period of slow involution, which may last for as long as 10 years. Concerning the imaging findings, it commonly presents as an extracorneal mass. It can also present as a transspatial mass, as you can see in this image, extending to the preceptor region of the orbit here. And it shows a very lobular contour. It is, again, T2 hyperintense lesion. And one important point now is the fine internal fold signal voice here. So the dark region here, linear and dog-like structure here are actually the internal fold signal voice, which indicate fast-flowing vasculature within the lesion. And being a vascular tumor, it shows intense homogeneous enhancement. And the lesion doesn't show any rich diffusion. So this is another patient with capillary hemangioma. So you may appreciate the extracorneal mass here with extension to the preceptor region. So this is a T2 sequence. So this lesion is T2 hyperintense, and you may see the branching and linear structures, which is hyperintense on T2 sequence, and it indicates the fold signal void. Same patient, different planes. So in corneal planes, again, we see the T2 hyperintense signal here and the fold signal voice here. It shows intense contrast enhancement, and there is no evidence of restricted diffusion. Finally, we talk about extracorneal tumors. As mentioned already, we think about soft tissue tumor or lesion or bone lesion is extracorneal space as representative pathology. And the three important ones are rhabdomyosarcoma, Langerhans cell histiocytosis, and neuroblastoma metastasis. Rhabdomyosarcoma is one of the most important pathology in this location. It is the most common mesenchymal tumor in children, most prevalent extraocular orbital malignancy in children, and the most common histologic subtype in orbit will be embryonal form. The mean age of presentation is around 6 years of age, and for the tumor behavior, it is a very aggressive lesion, rapidly growing, and the patient usually presents with progressive proptosis and swelling. And sometimes it is mistaken as orbital cellulitis because of the rapid growing nature of the lesions. And this will be a very important differential diagnosis to exclude. Most of them are extracorneal lesions, and it can also involve the intracorneal space. For the imaging findings, the most important part will be the invasiveness of the lesions. So bone erosions occur in 30 to 40%, invasion of paranasal sinuses in 20%. CT is very useful to look for the bone involvement. MRI is useful for the soft tissue involvement and the intracranial extension to the meninges. So in this patient, you can see the lesion is located in the extracorneal space here. For the tissue catheterization, it is iso intense to muscle on T1 weighted sequence and high signal on T2 weighted sequence. It shows moderate and marked enhancement, and the lesion will show restricted diffusion. So this is a high T2 signal lesion here. So this is a patient with rhabdomyosarcoma. So you may appreciate there is a huge soft tissue mass lesion in the center in the maxillary sinus on the left side with the orbital involvement here and is abutting the extraocular muscles here. And there is extensive bone destructions in the basal bones. And there is extension of lesion into the nasal cavity here, ethmoid sinus here, and over the other soft tissue regions in the face. And it shows contrast enhancement, as you can see in this post-contrast enhanced scan. So we have the DWI here. You may appreciate the high signal on DWI and the low signal in the ADC map. As mentioned, orbital cellulitis or even abscesses can sometimes present similarly. And this DWI will be very useful because if this is the central necrotic part being restricted in diffusion, then it will raise the concern that it may represent an abscess. If this is a necrotic component of rhabdomyosarcoma, we will expect it to have low signal on the high signal on the ADC map. And it is quite homogeneous in T1 and T2 sequence unless there is evidence of hemorrhage. So hallmark for the rhabdomyosarcoma is soft tissue mass with bone destructions and invasion. An important differential diagnosis to rhabdomyosarcoma are Langerhans cells, histiocytosis, and neoblastoma metastasis. For LCH, it usually center at the bone and destroy the bone. And for the neoblastoma metastasis, it also center at the bone, but present differently, sometimes with infiltration of the bone and with a lot of soft tissue masses. And this presentation is a very common a manifestation of these two conditions. And sometimes we will need the histological diagnosis because sometimes there are some overlapping findings between these kind of lesions. So here comes to my take-home points. First, to understand orbital imaging, we have to understand the spaces and contents in order to assess the orbital masses, the intraconal space and the extraconal space. And remember, there are several things that cause a space, and that will include the malignant tumor, neovascular, lymphatic structures, or infection. DWI is a very useful tool to differentiate a vascular lesion or high cellularity neoplastic lesion that we mentioned in rhabdomyosarcoma. Clinical cause again is as important as imaging findings, and as illustrated in capillary hemangioma and rhabdomyosarcoma. So here is my reference. Hopefully, this talk gives you some insights and understanding in imaging orbital masses and lesions that are applicable to your daily reporting. I'm Chris Wong from Hong Kong Children's Hospital. This is the end of my presentation on orbital masses and lesions. Thank you.